So being able to take care of yourself so that you can take care of your patients, I think is the most important. And I don't think that's specific to geri psych. I think that's the same like across the board for anybody in any specialty.
Welcome to the Specialty Café, the podcast that helps you, medical trainees, find your perfect specialty. My name is Wong, and I'm a fourth-year medical student at Queen's University. I'm joined by Dr. Nimrit Bath, also at Queen's University, and she is a PGY6 in Geriatric Psychiatry. And I'm here to talk about her specialty. Thanks for joining me, Nimrit.
Thanks so much, Cameron.
Do you think you could tell the audience a little bit about yourself before we get more into geriatric psychiatry?
Totally. So I think you did a really good job of introducing me. My name's Nimrit Bath, and I'm a PGY6 in Geriatric Psychiatry at Queen's. I'm also the current president of Resident Doctors of Canada, so I do a little bit of leadership on the side. I was born and raised in Newfoundland, and then my family had relocated to Ontario thereafter, and I actually went to medical school in Ireland at the Royal College of Surgeons in Ireland. And outside of medicine, I like spending time with my husband, Paul, and we enjoy, I guess, watching thunderstorms and playing board games.
Ooh, very nice. Nimrit, would you be able to tell me what is geriatric psychiatry?
So geriatric psychiatry is the study of psychiatry or mental health in older adults. So it's anybody who is above 65, but sometimes we do see people who are younger than 65 if they fulfill that like older adult type profile, like if there's lots of medical comorbidities or if there is a suspected cognitive concern that could be going on, because that's a lot of stuff that we are trained to do that is involving cognitive concerns and also taking that frailty into account as well, in addition to like full spectrum mental health work, right? So like depression, anxiety, substance use, all of those things too.
Mm-hmm. So I think a common gripe for pediatricians is that kids are not just smaller adults.
Yes.
Would you say the same goes for geriatrics and that like older adults are not just older adults?
Totally, 100%. So I think in older adults, especially, it's really important to take into account all of their life experiences, their wealth of experience that they do have, acknowledging all of those things. And in addition to that, there could be a whole host of like medical complications that could also affect different medications and when they can't be used. They can affect if therapy would also be helpful. Like we use a lot more non-pharmacological stuff as well to also help augment. And in some cases, we only use non-pharmacological approaches to treating patients. So it's more than just being an older adult, like especially when it comes to the subspecialties specifically.
Mm-hmm. That emphasis on like non-pharmacological treatment, I think, is opposed to some approaches where like a lot of times the treatments of psychiatric conditions in older adults is heavily associated with like only antipsychotics or only antidepressants. And so, yeah, it's good to hear about the emphasis on that as well.
Yeah, absolutely. It's probably one of the things that I like the most about the specialty. I know that sometimes in medicine in general, we have the tendency to use medication. We like using medication because it can be a quick fix for things. But when your non-pharmacological approaches, they're really integrated well. You work in a team, sort of all of these pieces are working really well. It does take longer and more effort to implement, but the outcome can be fantastic.
Mm-hmm. And geriatric psychiatry is, I guess, like a fellowship in addition to psychiatry.
Yes.
You're in your PGY 6th year.
Yeah.
What does the process of matching to psychiatry first and then going all the way to become a geriatric psychiatrist look like?
Mm-hmm. So psychiatry is it would be the prerequisite for getting into geriatric psychiatry, and that's a 5-year residency program in Canada. And now with the transition to CBD, when you do a geriatric psychiatry subspecialty, so you apply in your 4th year and then you transition in your 5th year to your, does that make sense?
Subspecialty. Yeah.
And you apply and then you go to the subspecialty within your 5th year and then you do an extra year on top of it.
I see.
So now if you're transitioning to a new site, or so you do psychiatry at University of Toronto and then you're there for 4 years, then you want to do the completion of your 4 years. Then at the beginning of your 5th year, then you transition to do 1 year of your subspecialty somewhere else.
Yeah.
And then you continue with your 2nd year there.
That makes sense. And I guess that goes I guess against what I would have thought, because I know that psychiatry is a 5-year residency. And so knowing that geriatric psychiatry is a 2-year fellowship, I would have added 5 plus 2 and added to 7, which is a lot of training. Yeah.
Totally. And I think that is one of the things that may deter people when they think about it, right? Because you're right, 7 years is a really long time to dedicate towards training, right? Being a resident is hard. And looking at the other side of things, you kind of wish for the light to be at the end of the tunnel and for it to come a bit sooner. But being able to do those 2 years right after your 4th year, I think is fantastic. It's only one extra year that you have to dedicate. And if it allows you to subspecialize and do what you really want to do, I would highly advocate that people do a subspecialty.
Yeah, that's good. When did you realize that you wanted to do geriatric psychiatry?
That's a good question. So even before med school, like throughout my whole life, I was raised by my grandparents as well. My paternal grandparents had a huge role in raising me. And my paternal grandmother was actually diagnosed with Alzheimer's dementia. And she passed away when I was in grade 12. But up until that point, towards sort of the the unfortunate end of her life, we did engage with community-based resources at that point as a family. And that was really beneficial. And seeing some of the other kind of clients that were there as well, and her and how much she loved going there, like it was really transformative for me. Just the fact that experiences like this do exist, and it's really like giving back to the people who raised you and who helped raise our generation as well. So it's extremely, to be able to be involved in it is extremely rewarding. And it was around then that I decided that I wanted to do work with older adults. My interest in psychiatry, like I was president of Psychiatry Society when I was in med school, so that kind of developed further on, and just being able to combine both things into my career moving forward, I thought that was like the perfect match for me.
Yeah, really sounds like it. Like, oh, really meaningful personal connection that you established.
Yeah.
With like seeing your grandmother connect with these resources, like in the community associations, and like being really well treated by them, and then seeing yourself as that, like in that position.
Totally.
Yeah.
Yeah.
Really great. Yeah, great path to where you are now.
Yeah, absolutely. And having that experience, being like a loved one of somebody who's gone through it, I can see the other side, right? So I can see the side where I'm interacting with patient family members all the time. That's part of one of the things that I like the most about the specialty itself. Like, no matter whatever work you're doing, it's not just about the patient. It is ultimately for the betterment of the patient, but it's involving kind of everybody coming around them and rallying to help them improve too. And that could be family members, friends, like they travel with their communities. So that within itself is also really rewarding.
That's good. Yeah. Hearing is like that's Carrie, for a patient in geriatric psychiatry is not just about the patients, but then the whole village that cares for them as well.
Oh, absolutely. Yeah.
It's good. Yeah, so that's really great to hear some details kind of about geriatric psychiatry as like a Royal College subspecialty. I want to expand the conversation to talk a little bit more about maybe what your day-to-day life looks like and get to know more about the specialty. What kinds of patients would you see on a daily basis as a geriatric psychiatry resident?
Sure. So it depends on the rotation that you're on. So we at Queen's do a mix of inpatient-based care. So we have the opportunity to have like a tertiary center treatment-resistant dementia unit. And there is where we do a lot of our inpatient-based work. So if patients are unable to remain safely in the community, or say they need a bit more time to get used to medication, or a safe place for a medication trial to be started, that's where they could be admitted. So I have spent, I think, upwards of 6 months there. And so taking or breaking down a day when I'm working on inpatient, We start rounding at around 9:30 or so every day. There's usually about an hour of pre-reading involved. We round on patients together as a team, and we engage with the multidisciplinary team as well. So there's full wraparound services that are provided. So having the ability to engage with like a behavioral technician is fantastic. Social work, we also have access to SLP or speech language pathology. Occupational therapy, as you can imagine, is also really important, and physiotherapy as well. If even people are unable to walk without assistance, being able to have access to like a physiotherapist to even do like a bit of walking, supported, obviously in a safe environment, or like a bit of assisted movement can be beneficial. Um, because people sometimes do get restless and then behaviors can develop, and we're trying to make sure that the joints remain well oiled and stuff like that too, right? Because if you don't, they always say if
Physical health is mental health
use
too.
and use it or lose it, right? So then we see that a lot of the time that people who remain in wheelchairs, especially if they're non-ambulatory, not being able to move even with a bit of assistance can really impact their quality of life on top of the other challenges that they already have.
Hmm. Having matched into internal medicine, I think I can really appreciate what you're talking about like the importance of multidisciplinary care and that
Yeah.
like you are a part of a team that achieving something that like none of you individually could do alone
Totally.
for your patients. And
Yeah.
so, yeah, I think that that definitely calls back to like the example of your grandmother when she was receiving care as well and getting
Yeah.
care from like a whole host of many, many different experts. So yeah, yeah, that's something that really appeals to me as well. The chance to work with many experts.
Totally. Absolutely. And it's one of the reasons why I love geriatric psychiatry. It's the ability to bounce ideas off of one another, especially if you have a really challenging case, that support, that ability to debrief before and after. And that you're able to like to explore different avenues. Sometimes people do bring up ideas that maybe you hadn't thought of. You're all working with the same goal in mind, and being able to engage with other specialties, allied health professionals, right? That are outside of medicine or complementary to medicine, I think it's amazing.
Hmm.
Yeah.
Yeah. So you kind of touched a little bit about on like the patients that you might see on like a daily basis as well as like your daily schedule. I
Yeah.
was wondering like to highlight like what really keeps you going as someone in geriatric psychiatry.
Yeah.
Do you think you could mention like what's like a case that you would say is most rewarding for you when you think about the types of patients that you care for?
Totally. So the most rewarding type of patient case is one where somebody is admitted to hospital because of really challenging behaviors in the community. They're living in long-term care. They're unable to sustain themselves there. The staff can't sustain them living safely there, right? And for us to be able to keep an eye on them living safely there from the community team perspective becomes very challenging. So when they are admitted to hospital, being able to see them engage with the team, and really sometimes it's the non-pharmacological approaches that I talked about earlier that can really benefit the patient. And sometimes maybe just the approach to the patient isn't right. We're just rushing them a bit too much and things like that, in addition to the medication, because that can also be complementary. But those are extremely rewarding and they are a lot of work to implement. It does take effort, like a lot more effort than to just give a pill
Right.
with the hopes that the behavior improves. But the mixture of the two and just seeing the complete change with like behavioral therapy or behavioral technology involved. We also do like observational scales just to ensure that objectively we aren't seeing any changes, and just seeing how sometimes quickly or even how stable they do become after like a really challenging time, for what could have been like a challenging discharge, if say that hadn't happened, is like extremely, extremely rewarding.
Having done, I would say, a fair amount of geriatric psychiatry during my own core psychiatry rotation in med school, I can really appreciate like, well, the amount of work that goes into like understanding the patient and like where they come from, who they rely on, the experience that they come to the hospital with.
Yeah.
It's certainly like a lot, but then also I do understand what you're saying about like the rewarding feeling of applying like primarily like non-pharmacological things like finding someone's glasses that like have been missing, or like finding them a room with a window and like watching them like kind of light up afterwards.
Yeah.
And also like deprescribing too, which is like a really, really big thing, very satisfying to kind of cut the med list in half and like almost seemingly watch them like, become a new person. Very
Totally.
interesting, I'm sure. Yeah.
Yeah, absolutely. Deprescribing is so integral to the work that we do, polypharmacy in particular. We know like sometimes medications can just be added on. And then it becomes hard because when we look at a medication list, it's hard to think about what is actually useful, what could not be useful. But looking at it with that critical lens, asking the patient and asking their family what could be helpful to take off, especially from a psychiatric perspective, and trying to wean that down a little bit with the caveat that if things really get bad, we can always go back on it, I think is a really good approach. And the important thing is to go really slow, like really carefully, right? Because there are a whole host of issues that can occur if we go too quickly. But to still be able to go, right? Like, I think there is a fine balance between the two, and I think that also is really important.
Mm-hmm. On the flip side of the more, I guess, like rewarding aspects, the most rewarding aspects of geriatric psychiatry, what would you say are the more challenging aspects of your specialty?
So the more challenging aspects of the work that we do are probably the ethical cases. Ethics is really important, especially with respect to like challenging patient and family encounters that we can come across. Families or caregivers can be the best advocates for the patient themselves, which is really helpful. But conversely, at the same time, sometimes we have different ideas of the care that should be provided at that point in time, right? So I think it's important in those moments to collaborate, and sometimes it can be helpful to get that ethical perspective into, like we have access to an ethicist at our hospitals in Kingston, and having that perspective as well can be very important.
Mm-hmm. Well, it's good that you have support for like those difficult cases where you might have to consult like the ethicist, for example, at Kingston General Hospital.
Yeah.
Yeah. And I guess like related to the aspects of the more challenging aspects of geriatric psychiatry, it is a specialty that is less acute than, let's say, anesthesia or ICU medicine, where oftentimes like your progress might be incremental over many days or weeks or months, years in that time span.
Yeah.
Acknowledging that, are there any like mantras that like you have for yourself, or like considerations that you use to kind of, I guess like reassure yourself or keep yourself going in the face of what you might see as like slow progress?
So I think it's important to not get bogged down that even a baby step with respect to progress is progress, but it's also important to take care of your own wellness, because a lot of the cases that we do see, they're chronic in nature. As we know, dementia, there's no cure for it, right? So it's a lot of symptomatic treatment, and psychoeducation around that for ourselves is also helpful. So it's progressive. It is going to get worse. It's just a different kind of timeline on when that does happen, depending on what the etiology is. And so for that, it's important to take care of your own wellness when you're taking care of some of these patients, because you can see the cases are becoming more and more complex. Like even as I go through residency, the population in general is just becoming really sick. So being able to take care of yourself so that you can take care of your patients, I think, is the most important. And I don't think that's specific to Geri Psych. I think that's same like across the board for anybody in any specialty, but more so for us when we see these chronic cases, it's hard for us because you can get bogged down by feeling that you're not improving anything, or you've tried so many different medications, so many different non-pharmacological strategies, you're trying your best, things still aren't getting better. And you may have to follow them potentially until the end of their life. So that within itself it's challenging to deal with, right? Because we go into medicine to help people get better, or a lot of us do, right?
Yeah.
And sometimes it's hard to accept that we have to there is no other side where people may get better, but
Mhm.
helping their symptoms in the moment and providing that holistic approach or
Yeah.
holistic treatment is also helpful.
And like the presence of you in that patient's life, and also like with other healthcare providers, knowing that they can rely on you in case they might not know how to manage certain behaviors or manage certain symptoms of like progressive diseases.
Yeah.
That in itself is a benefit as well,
Yeah.
for sure. Yeah. Well, yeah, thanks so much for answering those questions on like um, the finer details of geriatric psychiatry. I have a few last questions that are kind of like more of a mixed bag. The first of which is, well, in geriatric psychiatry, you treat older adults.
Yeah.
And oftentimes the advice is like to listen to elders and like, of course, like rely on the wealth of experiences, like you mentioned at the beginning.
Yeah.
Is there, well, what valuable lessons have you learned from your patients having like been in geriatric psychiatry residency so far?
Yeah. So I think one of like what I talked about a little bit earlier, like the one of the most rewarding aspects is the fact that the wealth of stories that your patients do carry with them. It's just it feels like um it's incomparable the fact that they trust you with some of the things that they do share with you and being you're in such a place of privilege to be able to kind of take little tidbits from some of those experiences. So when it comes to some things that my patient experiences have taught me, my patients have told me, it's that life is so short. It truly is so short. We can feel like we have however many years ahead of us, 60, 70, right? Years ahead of us before we think that we will then be in that position, but we don't know what can happen before then. So I think it's especially important, like with respect to our health and our well-being, knowing that we're in demanding professions to be able to take care of those things so that, again, we can take care of the patient population that we're trying to look after.
Yeah, it's a great, it's a great lesson, I would say,
Yeah.
to emphasize that life is short, and so to care for yourself, right? And another question, I guess, like I had related to like caring for people who are like of advanced age
Yeah.
is what kinds of things have you learned for your own personal life about like seeing people age that like you've brought back to apply to yourself? And I'm guessing it will probably be in similar line to lessons of to take care of yourself because
Hmm.
life is short, but then also to care for yourself early on is like a really huge gift to yourself later on. So yeah.
Totally. And I think when it comes to prevention, that is what a lot of when we see people more so in the community or in outpatient type clinics, we talk a lot about prevention type strategies, right? So trying to keep the brain healthy and what does that involve? So that involves your physical exercise, right? So I'm not a fitness expert by any means, but only within the last couple of years, I decided like something has to change. Life is going to continue being busy. I need to prioritize my physical wellness, my mental wellness, because there won't stop being another thing that I need to worry about, right? So those two pieces are really important. Nutrition is also really important. Um, Again, they always say if you don't use it, you'll lose it. So if you're like people are losing their hearing or having challenges with their vision, correcting that, right? So sometimes we do see patients who are admitted and their family member will then take their hearing aids home with them or their glasses home with them. And you can imagine that then that individual isn't interacting with anybody because they can't hear properly, they can't see properly. So then that can be very challenging for them. So giving them the best opportunity to be able to bounce back from whatever could be going on by offering them their senses back, right? So that they can do those things is really important. And then in addition to that, reading. Like I've started reading a lot more, but keeping your brain active. I'm a huge Wordle person. I'm still on that Wordle kick. What doing things like that are it's incredibly healthy for your brain to just to challenge it a little bit and think in so many different ways than how you would normally think, like critically, Sudoku, word searches, things like that, and can be it can be helpful. And we tell older adults to do them, but I think they could be helpful for anybody.
Yeah. Do you have a streak going with the Wordle?
I totally did. And I think just being on a couple flights within the last couple days, it's gone.
That's okay. Yeah. No. I really, really resonate with what you said about prevention. When I came into med school, one of the first ways that I felt was that I wanted to do something dramatic. I wanted to end up in a specialty where I was in the OR. I was operating on someone's heart, doing something like really difficult, like procedurally and technically. But I would say like my biggest like kind of dawning of realization as I've gone through the past 4 years is that it comes back to the basics of like really like the bottom level of Maslow's hierarchy, like food, water, shelter, sleep, and just basic things like you mentioned, nutrition, physical fitness. They're so key. And so that's really one of my personal biggest emphases, both in my life and like for my patients as well. So yeah, really key. And so I'm really happy that I got the chance to chat with you about all these different aspects of geriatric psychiatry. And I just want to wrap up this episode with asking, is there a piece of advice you would give your past med school self now that you've gone through medical school and almost having finished residency, to a piece of advice you give to your past self?
If I could give myself one word of advice, it would be, can I give myself 2 words of advice?
Yeah,
like this order. It would be to not give up on myself, and to keep going. So that would be my one word of advice in the past. Because when you are in med school, it's so easy to get wrapped up in the things that are going on and to feel like, this is the worst day of my life, right? But there's so much more outside of just that in the future, just in general, outside of that moment, that I think we need to be aware of, right? So it's important to just kind of truck through it and keep going, not in a bad way, like to the extent that we are making so many sacrifices, but to just the idea that there is a light at the end of the tunnel, right?
Yeah, there's a whole life ahead.
Exactly.
Yeah, that's really great. Thank you so much for the chance to chat, Nimrit, about geriatric psychiatry, a specialty that I now know to describe as one that's like really emphasized on like non-pharmacological things and emphasizing the importance of caring for like a patient, their wealth of experience, and then the whole village that supports them. Really like a broad and super important specialty. So yeah, I'm really grateful that I got the chance to chat with you.
Awesome. Thanks so much, Karen.
Thanks. Thanks so much for tuning in on this episode about geriatric psychiatry with Dr. Nimrit Bath. And if you are a resident in a Royal College affiliated specialty, remember to join as a resident affiliate member. It is free. We'll see you at the next episode. Thanks so much for listening.